बिस्मिल्लाहिर्रहमानिर्रहीम अस्सलाम वालेकुम। जिसे पेशेंट कहता है दिमाग का शोर, जिसे हम समझते हैं कान का शोर। जिसे पेशेंट कहता है दिमाग का शोर, जिसे हम समझते हैं कान का शोर। ये वही है टिनाइटस का मुअम्मा, तुम्हें याद हो कि ना याद हो। दिस इज डॉक्टर विजरा फ्रॉम शेख ज़ायद हॉस्पिटल लाहौर, एंड द टॉपिक ऑफ माय टुडेज presentation is tinnitus, symptom or sign, a case-based clinical approach. We as ENT care providers, we are very familiar with the term tinnitus, the sensation of ringing, buzzing, or any other sounds that come to the ears. But sometimes such patients present with very unique set of symptoms. For example, here, my patient 63 years of age, female, with the comorbs of diabetes and hypertension, she had complaints of persistent and bothersome bilateral tinnitus, which was associated with progressive hearing loss, vertigo, for the last 10 to 12 years. Previously, she had been a resident in a Gulf country where multiple doctors advised her and counseled her that it is associated with age related hearing loss, and she was altogether a neglected case until unless she thankfully visited Pakistan and one of her ENT doctors asked to get her pure tune audiogram. The PTA showed bilateral mild to moderate mixed hearing loss, and she was asked to use the hearing aids. But the hearing aids did not do any benefits to her. She was also advised to take ginkgo biloba or ceregen for the tinnitus part as a neurotonic. But her condition unfortunately worsened when she started to experience imbalance while walking. Tired, yet having the concrete pursuit to find the answers to the nuisance in the ears, she landed in our hospital at Sheikh Zayed, where we took her complete history, did her examination thoroughly, especially examination under microscope, where her bilateral tympanic membrane were normal with no significant abnormality. However, the tuning fork test had a very interesting inference. Right-sided Rennie positive, left-sided Rennie flipped. It was negative. The Weber was lateralized towards the right side. We ordered a repeat Puritan audiogram, and which showed this time left-sided moderate to severe degree of mixed hearing loss, and seeing the inference of tuning forks and the Puritan audiogram, the history especially, the way it was going cross roads. One thing we knew for sure, something big was cooking up. This kind of bothersome tinnitus for such a long time cannot be idiopathic. Soon realized अब तो कुछ और भी अंधेरा है. अब तो कुछ और भी अंधेरा है, ये मेरे केस का सवेरा है. रहजनों से तो भाग निकला था, अब मैंने पकड़ के गाइडलाइंस को घेरा है. So we took help from our alma mater, our fairy godmothers, our Mata Rani aka our guidelines, and we have nice guidelines as well as American Academy guidelines. And they state that if the history and the initial audiological examination, they state something questionable, please do not hesitate to get an imaging studies done. You, my dear, have got the permission slip to order the appropriate radiological imaging on the basis of your history and initial audiological examination. So we got an MRI with gadolinium contrast. And what I'm going to show you basically comes with the history of asymmetric sensory neural hearing loss rather than bilateral tinnitus. What we got was the answer to her questions. This, ladies and gentlemen, was the climax of the case. A 6.5 into 4.5 millimeter T2 hyperintense lesion at the left cerebellopontine angle that was suggestive of small intracanalicular acoustic neuroma. Once she was radiologically diagnosed, we arranged a multidisciplinary team meeting with the neurosurgeons on board who advised her to get gamma knife therapy as per the treatment plan. The ENT physicians, we do not have the duty to treat the tinnitus. Yes, you heard me right. We do not have to aim to treat the tinnitus, rather we have to triage it. try to basically diagnose whether it is a subjective tinnitus having the idiopathic cause or the objective tinnitus having some other causes, whether the symptoms they align with the audiological investigation that you are getting. And even if you have 1% doubt, use appropriate audiological imaging to confirm your diagnosis. And let's say if the imaging also comes out negative, then make sure that you rule out every other audiological, radiological causes, systemic diseases, or metabolic diseases that can lead to any tinnitus. If all is clear, then it is your duty to make sure that your patient receives the right tinnitus education management and counseling. My take home message is once you get any case that has atypical sensorineural hearing loss or you have persistent tinnitus along with it, use evidence based guidelines rather than labeling it as a case of randomly age related hearing loss or something that is not serious. Look deep to find the cause because early diagnosis and prompt treatment is like a stitch in time that saves 9. So next time a patient with tinnitus comes to you with a complaint of sounds in the ear and you hear your colleague from afar telling, "Bhai, ye to kaan ka shor hai," you tell them, "Galat," because now you know that tinnitus is a symptom and asymmetry makes it a sign. It is a proper case to be thoroughly investigated. Thank you so much for your patience hearing. And I have a disclaimer to make that this presentation is backed up by Veric Pharmaceuticals. Thank you.